Welcome back, guys. In this lecture, we continue with cardiac physiology. Probably this is the most high-yield lecture on this subject. I'm Dr. Duarte. I'm glad to be here with you. Let's get started. Let's start this lecture with the pressure-volume loop. Pressure-volume loop. This graph represents the relationship between left ventricular pressure and volume throughout the cardiac cycle. It's good to keep in your mind that everything happening here is inside the left ventricle. So as the cardiac cycle plays out, this is how pressure and volume change together. Okay? The loop moves counterclockwise, so follow it that way. Now let's focus on the green curve, the normal one. We start right here, where the mitral valve closes. That marks S1, mitral valve closes, the first heart sound. Since the mitral valve is now closed, this is the start of systole, right? At this point, the ventricle is full because I'm about to start a systole. Diastole just ended and the ventricle is full. This is the end diastolic volume, also called preload, right? You know that. Notice how pressure starts to rise sharply here, but volume stays constant. Volume is here, but the pressure is, rising sharply. That's because both valves are closed. No blood is going in or out. And this phase is called isovolumetric contraction. Iso meaning same volume, isovolumetric. And it ends when the aortic valve opens. Once the aortic valve opens, blood starts leaving the ventricle and loops drops. That drop from here to here is the stroke volume. The narrower the loop, the smaller the stroke volume. The wider the loop, the larger the stroke volume. Eventually, the aortic valve closes and pressure falls quickly, but volume stays the same. Volume stays here, but the pressure is falling here. This is isovolumetric relaxation. It's the phase between aortic valve closure and mitral valve opening. Again, all valves are closed here. Right before the mitral valve opens, we have the end systolic volume, the amount of blood left in the left ventricle after contraction. The difference between end diastolic and then systolic volume is your stroke volume. You know that. Next, the mitral valve opens and blood flows into the ventricle and the cycle starts again. Now let's look at some variations. This tall red curve here shows increased afterload, like in aortic stenosis. Increased afterload, like in aortic stenosis. You notice that pressure gets much higher, but stroke volume is smaller. The loop is narrower. Why? Because it's harder to eject blood against that increased resistance. Now look at the purple curve. This starts with a higher end diastolic volume, meaning increased preload. Think of it as giving fluids or doing a leg raise, for example. Because of the Frank-Starling mechanism, more preload leads to a greater stroke volume, so the loop is wider, right? And finally, check out the blue curve. It starts as the same preload as the normal loop. You can see here, same end diastolic volume, but it ends with lower end systolic volume, meaning the heart ejected more blood. That is, increased contractility. Seen with things like catecholamines or digoxin, the heart is just pumping more efficiently. This loop is very high for step 1, guys, so make sure you understand what shifts it and what those shifts represent clinically. Let's proceed. In this slide, we're showing how the loop behaves in both systolic and diastolic heart failure. The green loop is normal and the orange loops represents the abnormal states, right? So let's start with systolic heart failure. Here, the heart has a reduced ability to eject blood due to decreased contractility. So what happens to the loop? The curve shifts to the right, meaning the heart is now operating with more volume. It's volume overloaded. This is, pretty much the heart trying to compensate using the Frank-Starling mechanism, stretching the muscle more to get a stronger contraction. But look here, although the end diastolic volume, the preload, is higher, the stroke volume is actually lower. Why? Because contractility is reduced, so the ventricle can't eject as much. As a result, the end systolic volume is also higher. more blood remains in the ventricle after contraction. So the loop is shifted to the right and is narrower, reflecting reduced stroke volume despite higher filling. Now let's shift to diastolic heart failure. This is a problem of reduced compliance. The ventricle is stiff, often due to concentric hypertrophy, like in chronic hypertension, for example. It can't fill properly. So the loop shifts to the left. Here, the end diastolic volume is lower because the ventricle just doesn't stretch. It doesn't feed as much blood. Does that make sense? Even though contractility is normal, the stroke volume is still reduced because the total amount of blood available to pump is lower. So bottom line is, in systolic heart failure, the ventricle is weak, it can't empty well, the curve shifts to right, working with more volume, even though the stroke volume will be low. In diastolic heart failure, the ventricle is stiff, it can't fill well, so the curve is looped to the left, and although the contractility is good, is normal, because the amount of blood is lower, the stroke volume will still be lower, okay? In both cases, you end up with reduced stroke volume, but for different reasons. Now let's go over the pressure volume loop in the setting of valvular pathologies. Very high yield. You will start with aortic stenosis. Let's go. So, in aortic stenosis, the aortic valve is narrowed. That means that left ventricle has to generate much higher pressure during systole just to open that valve and eject blood. Much higher pressure during systole just to open the valve. This is a classic example of increased afterload, more resistance to outflow. So during systole, the ventricle needs to push pressure way up, and you can see that here, the loop becomes taller. But because of that obstruction, less blood is ejected. So the stroke volume decreases and the loop becomes narrower. Also notice the end systolic volume increases. Why? Because the heart is working harder, but it still can't eject as much blood, right? So more blood remains in the ventricle after systole. So the pressure volume loop in aortic stenosis shows pretty much, bottom line, increase afterload, increase, systolic pressure, increase end systolic volume, decrease stroke volume, a tall and narrow loop. That's what you're going to see. This reflects the classic physiology of a pressure overloaded left ventricle. Let's continue. This is the pressure volume loop in aortic regurgitation, and this one has a very different pattern. So what's going on here? In aortic regurgitation, the aortic valve doesn't close properly, which means that during diastole, instead of staying in the aorta, some blood leaks back into the left ventricle. Now think about that. During diastole, the ventricle is already filling from the left atrium, right? And now it's also receiving extra blood coming backward from the aorta. So what does that do with the pressure volume loop? First, end diastolic volume, preload, increases a lot, because more blood is entering the ventricle, so preload increases. That pushes the right side of the loop further out, showing us a state of volume overload. Volume overload. Then, during systole, the ventricle tries to compensate. It has more volume, and it contracts more forcefully. So you often see an increased stroke volume, and the loop becomes wider. And remember, on physical exam, you'd see a widened pulse pressure because systolic pressure goes up from the highest stroke volume, and diastolic pressure drops, of course, due to the backflow of blood into the ventricle. But here's the catch. Even though the ventricle is ejecting more blood, some of that blood is leaking right back in, so the net forward output may still be low. Keep that in mind. Let's take a look at the loop. There are no true isovolumetric phases. That's a high yield information. Why is that? Because the ventricle is never truly closed. Either, blood is coming in from the left atrium or leaking back from the aorta. So no isovolumetric phases. So the isovolumetric contraction and relaxation phases will disappear. The loop loses those straight vertical lines. And instead you get this, slanted look. Let's break it down. During isovolumetric contraction, in a normal heart, the mitral valve and aortic valves are both closed. Pressure builds with no change in volume. But in aortic regurgitation, the aortic valve is incompetent, okay? It's incompetent, so pressure rises. But some blood is already leaking out, so it's not truly isovolumetric. Same idea for isovolumetric relaxation. After ejection, when the aortic valve should be closed, blood is still leaking back in. So again, no phase where volume is constant, okay? So to summarize, the key features of aortic regurgitation, so you master it. We have increased end-diastolic volume from regurgitant backflow, increased stroke volume as a compensatory response, no isovolumetric phases because the ventricle is never fully closed, a wider, more rounded loop, right? And this is a classic pattern of volume overload, not pressure overload, okay? So remember that. Now let's go through the pressure-volume loop in mitral stenosis. So what's going on in mitral stenosis? The mitral valve is narrowed, so less blood gets from the left atrium into the left ventricle during diastole. That means we start with lower end-diastolic volume. The ventricle just isn't receiving as much blood. So what happens to the loop? Since there's less volume to begin with, the loop shifts to the left because preload is reduced. You also notice that the stroke volume is lower, the loop is narrower, simply because there was less blood available to eject. Now pay attention to the height of the loop as well. Systolic pressure might stay normal if contractility is preserved, which usually is in cases of mitral stenosis. But the main issue is that the ventricle doesn't fill properly. So even with normal contractility, the output is reduced. Here's something important. The problem is not the ventricle itself. The ventricle is fine. It's just, isn't getting enough preload. So this is a case of underfilling, not pump failure, underfilling. So the isovolumetric phases are present. In this case, both valves can still close properly. So you still see the vertical lines on the loop, And to summarize the key features of mitral stenosis on the pressure volume loop, you have decreased end-diastolic volume, less blood entering the ventricle, so decreased end-diastolic volume, decreased preload will lead to decreased stroke volume, think, about the Frank-Starling mechanism. Loop is narrower and shifted to the left. Isovolumetric phases are preserved. This is a pattern of impaired filling, not contractual dysfunction. Okay, let's go. Mitral regurgitation. This one has a very characteristic pattern, and it's important to understand what's happening during both, systole and diastole. So what's the issue in mitral regurgitation? Let's remember. The mitral valve doesn't close properly, which means that during systole, when the ventricle contracts, some of the blood leaks backward into the left atrium instead of going forward into the aorta. Let's walk through what that does to the loop. First, during systole, the ventricle is contracting, but not all of that volume goes forward. Some leaks back into the left atrium. So the effective stroke volume is reduced. Even though the total volume ejected, forward plus backward, it might look high. And now, what happens during diastole? That regurgitated blood flows right back into the ventricle, along with the normal pulmonary venous return, so the ventricle fills with more blood than usual. This increases end-diastolic volume, or preload, which shifts the right side of the loop further out. You're dealing with volume overload. Now here's the key detail. Just like in aortic regurgitation, there are no true isovolumetric phases. Why? During isovolumetric contraction, the mitral valve should be closed, but it's leaking, so volume is changing. During isovolumetric relaxation, again, the valve is leaking, so blood flows while the ventricle relaxes. Okay? So in mitral regurgitation, the loop loses those vertical lines, vertical sides. It has that slanted appearance because volume is never stable between valve events. Now let's sum it up. In mitral regurgitation, we have increased end-diastolic volume due to volume returning, from both the left atrium and pulmonary circulation. We have increased total stroke volume, but effective forward stroke volume is reduced. No true isovolumetric phases. Both contraction and relaxation are disrupted. Wider slanted loop, typical of volume overload, and it leads to eccentric hypertrophy over time. Okay? So this is a classic example of a volume overload lesion. And just like aortic regurgitation, over time the ventricle dilates in response. Let's continue. All right, let's take a look at this big integrated cardiac cycle diagram. Extremely high yield for step 1. You need to understand everything is going on here. Everything is happening at once. Pressure changes, valve movements, heart sounds, electrical activity. But don't worry, I'm going to break it down step by step. On the x-axis, we have time. On the y-axis, we are tracking multiple things happening in sync. Pressure, heart sounds, volume, ventricular volume, jugular venous pulse, and ECG. This is a great summary on how everything in the heart works together during each heartbeat. Let's start by focusing on the top 3 pressure curves. Left ventricular pressure, aortic pressure, and left atrial pressure. We begin right here, where the mitral valve closes. That marks the start of systole and the beginning of isovolumetric contraction. At this point, all valves are closed. You know that. So the left ventricular pressure starts rising quickly, but there's no change in volume. If you look at the ventricular volume curve here, the line is flat, right? That's why we call it isovolumetric, same volume, increasing pressure. Next, once left ventricular pressure exceeds aortic pressure, then the aortic valve opens and blood starts to eject into the aorta. Notice here, from that point on, left ventricular and aortic pressure tracks closely together during rapid and reduced ejection. Okay? They track closely together. You also see that the ventricular volume curve start to drop here. That's blood leaving the ventricle during systole. Eventually, aortic pressure drops below left ventricular pressure and the aortic valve closes. That little bump on the aortic pressure curve, what is that? That's the dicrotic notch. High yield, dicrotic notch, caused by brief backflow of blood hitting the closed aortic valve. Now we enter isovolumetric relaxation. Again, both valves are closed, so pressure in the left ventricle drops quickly, but volume stays constant. Again, if you look at the volume curve here, there is another flat, kind of a flat segment. Again, no volume change because both valves are shut. Then, when left ventricle pressure falls below left atrial pressure, then the mitral valve opens and the ventricle starts to fill again. That begins diastole. Now take a look at the green dashed curve. This is left atrial pressure. It rises first during atrial contraction. That's the A wave right before systole. It rises again during ventricular contraction as mitral valve, kind of bulges back into the atrium. That's the C wave. Then as the atrium relaxes, you get the X descent, a pressure drop. After that, the atrium starts filling while the mitral valve is still closed, which causes the V wave. Notice that left atrial and ventricular pressure sit close together during diastole, since the mitral valve is open and the pressure are nearly equal. Now let's line it up with the heart sounds. S1, that's when the atrioventricular valves close, making the start of systole. S2, that's when the semilunar valves close, making the start of diastole. If present, S4 occurs before S1 during atrial contraction. That's a pre-systolic sound. S3 would come, right after S2 during rapid filling. Don't worry, you go into heart sounds and jugular venous pulse curve in more detail ahead, okay? And finally, if you look down at the ECG, you see QRS complex, that's ventricular depolarization, and it lines up with the start of systole. All right, let's go over these cardiac cycle pressure curves, now integrating the left ventricle, aorta, and left atrium in the context of different valvular pathologies. We have the normal curve here as reference, and by the way, if they look wider than the abnormal curves, don't worry, That's just the scale of the drawing. It doesn't mean anything clinically. Let's focus first on aortic stenosis. In aortic stenosis, the left ventricle has to generate a much higher pressure during systole to push blood through the narrowed aortic valve, so afterload is significantly increased. Now look closely. You see that the left ventricle pressure rises much higher than the aortic pressure. That's not what happens in the normal heart. Normally, aortic pressure and left ventricle pressure rise together once the valve opens. But in aortic stenosis, they separate. The left ventricular pressure is much greater than the pressure it's ejecting into. And that difference, where left ventricular pressure exceeds aortic pressure during systole, is your classic hemodynamic clue for aortic stenosis. That pressure gradient, left ventricular greater than aorta during systole, is exactly what you would expect with a tight stenotic valve that's resisting flow. Aortic regurgitation. Here the aortic valve is insufficient, meaning it doesn't close properly. So during diastole, instead of blood staying in the aorta, some of it leaks back into the left ventricle. Now what happens to the pressure curves? Look at the aortic pressure curve. You see that the diastolic pressure falls rapidly. As a result, you get a wider pulse pressure. Systolic pressure is elevated due to increased stroke volume, and diastolic pressure is low due to the regurgitant flow. And here is a key finding. The dicrotic notch is absent. That's the thing you need to know. Why? Because the aortic valve doesn't close properly, so there is no sudden stop to flow. You don't get that brief rebound wave you normally see when the valve shuts. This is a classic giveaway on pressure tracings in aortic regurgitation. Mitral stenosis. The key issue is that the mitral valve is narrowed, which means that during diastole, the left atrium can't empty properly into the left ventricle. And here's your classic clue on the pressure curve. The left atrial pressure remains elevated throughout diastole. That's your clue. Let's walk through that. In a normal heart, after the aortic valve closes and the mitral valve opens, left atrium and left ventricular pressure should come close together during diastole because blood flows easily from the atrium to the ventricle. But in mitral stenosis, that doesn't happen. Instead, there is a persistent pressure gradient between the left atrium and left ventricle during diastole because blood is trying to pass through the tight, stenotic valve. That's why you have this, higher pressure here throughout the cardiac cycle. Now let's take a look at mitral regurgitation. The key issue here is that the mitral valve doesn't close properly during systole. So when the left ventricle contracts, some of the blood leaks backward into the left atrium instead of going forward into the aorta. So what does that do to the pressure curves? Focus on left atrial pressure. You notice that it rises abnormally during systole. That's because the atrium is receiving blood not just from the lungs, but also from the ventricle pushing blood back into it. This makes this V wave on the left atrial pressure curve much more prominent, a classic finding in mitral regurgitation. That tall V wave during systole is your clue. It tells you there is a regurgitant volume coming back into the atrium during systole. Okay? Did you get that? Let's continue. All right. Let's go over the hard sounds and place them into context in cardiac cycle. Easy peasy. We start with the basics, S1 and S2, and then we're going to talk about extra sounds, S3 and S4. S1 first, it's caused by the closure of the mitral and tricuspid valves, the atrioventricular valves. That marks the start of systole. You know that. You're going to hear it best at the mitral area near the apex of the heart. So this is when the ventricle starts to contract, atrioventricular valves close to prevent blood from going backwards into the atrium. Okay? S2 comes next. It's the closure of the aortic and pulmonary valves, the semilunar valves. That marks the end of systole and the start of diastole. You hear this one best at the left upper sternal border. So again, S1 is the atrioventricular valve closure, systole starts. S2 is semilunar valve closure, systole ends, diastole begins. Now let's go over extra hard sounds, S3 and S4, more high yield than S1 and S2. That would be easy, right? Both of them occur during diastole, but at different times. S3 happens in early diastole, right after S2, tu-tra, something like that. This is when the mitral valve opens and blood rapidly flows from the left atrium into the left ventricle. Now imagine this. If the ventricle is dilated or already full, that incoming blood hits it hard, and the turbulence produces this S3 sound. It's a low-pitched sound, best heard at the apex, with the patient in left lateral decubitus position. Think about conditions where the ventricle is stretched, is full, like mitral regurgitation, aortic regurgitation, heart failure, high output states like thyrotoxicosis, for example. So S3 is a marker of volume overload, usually for an eccentrically hypertrophied heart or failing heart. But here is the nuance. S3 can be normal in children, young adults, pregnancy, and athletes. In older adults, though, it's usually pathologic. S4 is different. It happens in late diastole, just before S1. So it's pre-systolic, like through ta, something like that. It's associated with the atrial kick, when the atria contract and push blood into the ventricle. Now, if the left ventricle is stiff or non-compliant, like in concentric hypertrophy, that atrial contraction has to push harder, and the turbulence it creates produces an S4 sound. This is not a normal finding. Especially in older adults, it suggests diastolic dysfunction. S4 is also best heard at the apex in the left lateral decubitus position. Okay, let's go. Now let's go over the types of splitting of the second heart sound. S2, something step 1 loves to test, especially when linked to, timing and valve physiology. We start with the normal, and then we move into the pathologic patterns. Physiological splitting of S2, this is normal. During inspiration, P2, pulmonary valve closure, happens slightly after A2, aortic valve closure. Why? Because inspiration reduces intrathoracic pressure, increasing venous return to the right ventricle, which prolongs right ventricle systole, so the pulmonary valve closes later. You hear a split S2 during inspiration, and it fuses back together during expiration. It's especially noticeable in young, healthy people. Wide splitting of S2, this is like an exaggerated version of physiological splitting. So you hear a split during inspiration, but now the split is wider and persists even during expiration, although it's more obvious during inspiration, okay? This happens when right ventricular systole is prolonged. Common causes include pulmonary hypertension, pulmonary stenosis, right bundle branch block, massive pulmonary embolism. So when you hear a persistently wide split that gets more exaggerated on inspiration, think of prolonged RV systole. Fixed splitting of S2. Now this one is very classic, and you need to know a code, okay? In fixed splitting, the interval between A2 and P2 is the same during both inspiration and expiration. It doesn't vary with breathing. Basically that. And this is classic for an atrial septal defect, ASD. Here's why. In ASD, there is a left to right shunt, right? Left atrium has higher pressure, so blood is constantly flowing into right atrium and ventricle, increasing volume and delaying pulmonary valve closure all the time, no matter what's happening with breathing. And since the right heart is already volume overloaded, inspiration doesn't add much, so the split stays fixed. That's why, okay? All right, did you get that? Paradoxical splitting of S2. This one is called paradoxical because it's the opposite of what you expect. In paradoxical splitting, you hear A2 after P2, and the split is most noticeable during expiration, not inspiration. This happens when aortic valve closure is delayed, so A2 comes late and ends up, occurring after P2. Now, during inspiration, the pulmonary valve closure is also delayed, so P2 and A2 overlap, and the split actually disappears. This is called reversed splitting or paradoxical splitting, and the most common causes are aortic stenosis, left bundle branch block, hypertrophic cardiomyopathy, right ventricular pacing as well. So if you hear a split S2 that disappears with inspiration, think paradoxical splitting. That's your clue for delayed aortic valve closure. Okay? All right. Next, let's talk about the jugular venous pulse, or JVP. Don't worry, you're going to understand that and you're going to remember that. It reflects the pressure change in the right atrium and right ventricle during the cardiac cycle. It's actually helpful, non-invasive way to assess right heart function. We observe it through the internal jugular vein, usually with the patient at 30 to 45 degrees. Now let's go over the 5 components of the waveform. We basically have 2 waves, the A wave and the V wave, right? The C wave is minor. It's mainly the tricuspid valve being pushed back during right ventricular contraction. We talk about it. So again, 2 main waves, A and V, okay? And then 2 descents, X and Y. 2 waves, A and V, 2 descents, X and Y. Let's break them down and make sense of each one. A wave, A for atrial, okay? Atrial contraction, this represents right atrial contraction, A wave. Easy peasy, right? And it happens right before systole, right before S1. So if this is systole, here's S1, here's S2, right before S1, at the very end of diastole, the atrium contracts, pushing blood into the ventricle. That creates this A wave in the jugular pulse. Now let's think together. If a patient has atrioventricular dissociation, like complete heart block, the A wave becomes very prominent because the atrium and ventricle are no longer working together. So the right atrium might contract against a closed tricuspid valve, or even at the same time as the ventricle. That's what gives you those canal A waves. So canal A waves, okay? But if the patient has atrial fibrillation, for example, there is no organized atrial contraction. So the A wave disappears, is absent, okay? Did you get that? C wave, this reflects right ventricular contraction. As the ventricle contracts, the closed tricuspid valve bulges back into the atrium, causing a brief bump in atrial pressure, and that's the C wave. X descent. This descent represents atrial relaxation and downward movement of the tricuspid valve during ventricular systole. It's usually a sharp drop. But now think about it. If the patient has tricuspid regurgitation, the valve is leaking during systole. So when the atrium should be relaxing, instead blood is coming back into it. That prevents the pressure from failing, and the X descent is absent. Okay, so in patients with tricuspid regurgitation, we don't see the X descent. Same thing in right-sided heart failure. The atrial pressure stays elevated and the normal drop disappears. V wave, this wave reflects passive filling of the right atrium. Passive filling against a closed tricuspid valve, right? During systole, remember the atrioventricular valve is closed, and I want the blood going forward, not back. So while the ventricle is ejecting, the atrium is relaxing and filling, and the venous return from the body keeps coming in, and that blood builds up until it reaches its peak, and that's your V wave. And finally, we have the Y descent. This represents emptying of the right atrium into the right ventricle. It happens when the tricuspid valve opens. During systole, the right atrium is getting filled, right? And the tricuspid valve is closed. When it opens during diastole, that blood just falls into the right ventricle, and that's the Y descent. Now, here's a classic step 1 detail. In constrictive pericarditis, early filling is kind of exaggerated. The ventricle fills quickly and then abruptly stops when it hits the pericardial limit. So the Y descent is sharp and prominent. That gives you a waveform that looks like an M or W. We call it a square root sign, okay, or dip and plateau pattern in some contexts. So when you see a square root sign on the venous pulse, you'll think about constrictive pericarditis. On the other hand, in cardiac tamponade, the Y descent is absent. Why? Because the fluid in the pericardial sac restricts ventricular filling, so even when the tricuspid valve opens, the blood can't flow properly into the ventricle. and there is no meaningful pressure drop in the atrium. Okay? Guys, I hope you enjoyed the lecture. That's pretty much it for today. I hope you learned something valuable. See you next time.